Hello physio friends, I am Sudarshan Joshi, instructor from BRAWN Institute. In last video we have discussed a case study over the forward head presentation, and in that we have already seen that forward head presentation is comprised of three things: head presentation, thoracic kyphosis or upper thoracic flexion, as well as rounded shoulder. So in today's video we are going to discuss in detail about the head presentation in forward head posture. As we already familiar with that head presentation comprised of two things, that is upper cervical extension and lower cervical flexion. But did you notice when you observing a patient with forward head posture that few has very long neck, a long and mobile neck, and on opposite side few has very short and stiff neck. Definitely both have up forward head, but why these variations? So today's video is about to explain about these variations, why these are differences occur in neck presentation in forward head posture, what are the reasons and corrective exercises. So let's start. For sake of understanding, we can divide a head presentation into three stages. In stage 1, a presentation will be patient have a forward head with a long and mobile neck, and this presentation only appear when the stimulus is there. We already discussed about the stimulus, that is disturbance for the center of gravity that creates forward head reaction. So forward head presentation exists till stimulus is existing. Patient has excellent ranges in neck, a very long neck or appropriate length of neck. Second thing, whenever he lies supine, so we all are familiar that when a patient with forward head lies supine, they got an extended head attitude if they are not using pillow. So when in this stage when patient lies supine without pillow, they don't require to assume this extended head posture because they have no restrictions, so they lie supine comfortably without a pillow. Next thing, they are able to retract their head comfortably with excellent range, because in most of the forward head cases they have either pain or less range in head retraction. This was the first stage. If stimulus, that disturbance of COG, if stimulus is still existing, then a person change into second stage. It moves into second stage. In this second stage, adaptive changes started. So adaptive lengthening or shortening of corresponding neck tissues. So let's see in detail what are the facial or muscular tissues that goes into adaptive shortening or lengthening. So now let's see about the musculature those underwent into shortening or lengthening, adaptive shortening or lengthening. So first of all, obliquely oriented muscles: sternocleidomastoid, upper trapezius, anterior scaleni, obliquus capitis superior, rectus capitis posterior, minor and major. These are the muscles obliquely oriented and get adaptively shortened. Next muscle group is deep neck flexors, constitute three muscles: rectus capitis anterior, longus colli and longus capitis. Out of these three, rectus capitis anterior and longus capitis, get adaptively lengthened and longer scoli get adaptively shortened, thus contribute in upper thoracic kyphosis also. Next, posterior extensor group. So when we discussed muscles lying in posterior or extensor compartment of the neck with forward head posture, it has tremendous load because due to as head shifted forwardly, now the load of head increases tremendously, and the task required is that to level the eye and head. And for this task, leveling the eye and head, two muscles require tremendous work. First, already discussed, rectus capitis posterior major, along with other suboccipital muscles. Second one is semispinalis capitis. This muscle has a strategic orientation, and as head goes forwardly, now responsibility of this muscle increases tremendously, and it assumes a adaptively shortened position again in the task to level the eye and head. As this muscle gets shortened, overworking develops triggers. So triggers in upper portion of semispinalis capitis causes a pain over the strap between the lateral side of eye to the ear, a lateral strap between eye and ear. Along with this upper part also responsible for entrapment of greater occipital nerve. In the lower part, this part can refer pain into ipsilateral occipital area. So, two important muscles, rectus capitis posterior major and semispinalis capitis, they are working very hard to level your eye and head coordination. So now, adaptive shortening in semispinalis capitis and rectus capitis posterior major, this also compromise the capacity of neck to get a symmetrical flexion. Ideally, flexion should get well distributed throughout the cervical spine and thoracic spine. But due to these two tight muscles, now upper cervical as well as middle cervical not involved in flexion. So maximum flexion is came out from lower cervical and upper thoracic. Next muscle is levator scapulae. Again, as with forward head posture, its both attachment goes apart, it strapped into eccentric loading. And whenever there is activity of upward rotation of scapula, that is hand elevation, or other activities of scapula, it gets eccentrically pulled, and it has a pain pattern over the angle of neck. So let's move to the third stage. After these adaptive changes, in third stage, due to the forward shift of head, stability mechanism of head over the thorax get compromised as weight of head now increased tremendously. So natural physiological stability mechanism now become inefficient. To compensate that, now pectoral girdle or shoulder girdle involved in head stability mechanism. Ideally, shoulder girdle and head operate independently, but now shoulder girdle get one new work, that is to stabilize the head. And for this stabilization, your upper trapezius get activated and it become overactive and hypertrophied. Result is slightly elevated shoulder. So in stage 2, due to overactive semispinalis capitis, your neck get shortened. Second, due to elevation of head in third stage, further it reduces the length in presentation. So when you look a patient with forward head which already passed stage 2 or 2 phases, that is now he has become adaptively shortened, his neck is short and stiff. So that is the reason to a shortened neck. And the pathomechanics yet not stopped. It further goes on. As we already discussed that in forward head posture there is overactive pectorals. Those who have not seen the earlier video, please go through that so that you can understand more about this video. So now due to the overactive pectorals, the rounded shoulder presentation, one more thing happened. So just do one experiment. Try to extend your neck. Try to extend your neck and check the range of movement, feel the end field. Followed by, now protract your head as much as you can, and then with protected shoulder again go to the extension. Yes, now extension was reduced and slightly painful. Why? It's because of tight pectorals. Due to your rounded shoulder presentation, now the middle trapezius goes into eccentric loading. We already know it starts from the lower cervical 5-6 segment and extend up to the mid-thoracic level. So whenever your middle trap goes into eccentric load, it fixes your lower cervical spine. For extension, we need a slight spinal slide posterior-inferiorly. This is blocked by a tight or eccentrically loaded middle trapezius. So now, actually, physiologically, when extension of neck occur, it should well expanded or equally distributed in cervical spine as well as in upper thoracic spine. So expansion of extension should be well distributed at C curve. But now as your lower cervical spine, from lower cervical spine it is blocked due to the middle trapezius. Now extension occur in only 2-3 segments, especially 4, 5 and 6. So now it is more angular rather than a symmetrically distributed extension. Now it becomes more angular. And now if a patient with forward head want to see the roof or want to see upward, he has only options C4, 5 and 6. So in these 3 segments has responsibility to provide a range. That's why these 3 segments goes into hypermobility, and occasionally you may find skin creases almost in these areas. And this is one probable reason for why cervical disc pathology or facet dysfunctions occur mostly in these 3 segments, C4, 5, C5, 6, because they get high in hypermobility to compromised or unavailable mobility in upper and lower thoracic spine. So upper cervical spine and lower thoracic spine don't have extension mobility, so they are get hypermobile. So that was the pathomechanics of head presentation. Now let's discuss about some treatment consideration. Definitely a dedicated video over the treatment of forward head posture will be there. So what is most common exercise came into our mind, or if you will observe many programs that includes exercise for the forward head, what it includes? Yes, it is chin tuck or head retraction exercise. And in various exercise protocol, various variation of this chin tuck exercise are included, either in supine, either over the foam roller, either with sitting in chair or with wall support standing. But mechanism is same, head retraction. So let's discuss in brief about what is physiological head retraction, mechanics behind the head retraction, and then we will see about some common compensations or mistakes we always used to do with head retraction. So head retraction, it comprises of 3 steps. First is the activation of your deep cervical flexors, that comprises of longus colli and capitis and rectus capitis anterior. These are the deep spinal flexors. They have work to elongate the spine. Over these, our flexors of the neck, especially muscles that are attached to the hyoid, digastric, sternohyoid and other muscles group, or a posterior muscles, that is extensors of the neck, they are work over this postural framework. So this postural framework is provided by the deep spinal flexors, these 3 muscles. So first step is the activation of deep neck flexors. In second step, over this elongated spine, now semispinalis cervicis activates and extend your lower cervical and upper thoracic spine. So a retraction of head means just retract the head with the mobility of upper thoracic spine, especially upper thoracic spine. So an elongated cervical spine get retracted, and this is done by semispinalis cervicis. Step third, this also includes a stabilized sternum. Over this stabilized sternum, when you retract your head, your sternocleidomastoid and upper trapezius get stretched. So this is the physiology or mechanics behind the chin tuck posture or chin tuck exercise. Now to achieve this physiological retraction, we require some prerequisite. What are the prerequisite? First one, a relaxed suboccipital as well as semispinalis capitis. So until unless these muscle group not get relaxed, we are not get recruited our rectus capitis anterior as well as longus capitis, part of deep flexor group. So these 2 muscles need to be relaxed. Second, availability of upper thoracic spinal movement or mobility. So until unless extension will be available in your upper thoracic spine, head retraction will not be capable. Now the third thing is that all your obliquely oriented muscles should get relaxed and lengthened so that you can achieve a full range of head retraction. Until unless we can fulfill these prerequisites, a full head retraction, physiological retraction will not be available. Yes. So before doing any retraction exercise, we need to fulfill these prerequisites. Yes, one can achieve this prerequisite as well as retraction simultaneously, but it requires a graded and individualized exercise program for a particular patient. So now let's move to the common compensations or mistakes during the chin tuck exercise. So first one is that if upper thoracic mobility is not available, patient will compensate with thoracolumbar extension or the lower thoracic extension. So whenever you perform this exercise with support of wall, must check that thoracolumbar junction should not go into extension. Second one is very much common. It's lifting up of sternum and your shoulders. Why this occurs? So place your one hand over the sternum and perform chin tuck. And if while performing chin tuck your sternum goes up, what it means? It means your sternocleidomastoid is still tight. So first work up for adequate lengthening and then only perform the chin tuck. Why it is happening? Because we had two attachments, proximal and distal attachment. When you perform a chin tuck, proximal attachment goes further. As muscle is not relaxed, it further pulls its distal attachment. So with chin tuck, your sternum goes up, and when you leave your chin tuck or you relax, it again retain your same position. So if adequate lengthening is not present, either in trapezius, if trapezius is there, patient may elevate his shoulder slightly, or if SCM is there, patient may elevate his sternum. So these two common mistakes. Now how to conquer? So for first thing is that you need to stabilize your sternum and shoulder. One simple thing is that you can achieve this while providing tactile cue by patient himself. So just ask him, don't let your sternum and shoulder go up while performing extension. Second one, you can give a very good cue is that you should perform chin tuck when you exhale, because during exhale your transverse abdominis get activated. So ask him to prolong exhale and while exhaling perform the chin tuck. It will physiologically stabilize your sternum. Next thing we can do is stabilize the sternum via body weight. So again two positions. One, directly stabilize the sternum via body weight, or stabilize the sternum while selecting a particular frame so that sternum is now stabilized, and when a patient performs chin tuck in this particular frame, it will get adequate lengthening. That's why I discussed about either first way is that first complete the prerequisite for the chin tuck exercise or head retraction, then only proceed to the head retraction. Next important thing is that in the chronic cases, when your suboccipitals get short, tight and sensitive, whenever patient perform a forceful retraction, it might get a giddiness, nausea or headache. These all symptoms are correlated with your suboccipital muscles. So in previous video we discussed about the mechanical prospect of forward head posture. In this we discussed in detail about the pathomechanics of head attitude. In upcoming we will discuss about the rounded shoulder, and then the last video of this series will be over the treatment. So full dedicated video over the treatment prospect. Thank you very much. See you soon.